Bismillahirrahmanirrahim. Today we are going to discuss Hodgkin lymphoma. Two major types in lymphoma. One is Hodgkin lymphoma and the other is non-Hodgkin lymphoma. Today we will discuss Hodgkin lymphoma. Hodgkin lymphoma encompasses a distinct group of nucleae that are characterized by the presence of a tumor giant cell. This tumor giant cell is known as the RS cell, Reed-Sternberg cell. Hodgkin lymphoma arises in a single lymph node or a chain of lymph nodes and typically spreads in a stepwise fashion to anatomically contiguous lymph nodes, to the nearby lymph nodes. This is its typical feature for spreading. The Reed-Sternberg cell, this is the actual malignant cell in this disease. Reed-Sternberg cell, RS cell, this expresses CD15 and CD30, and this fails to express CD45, B cell antigens and T cell antigens. Now these are some differences. This table just to show you what is the Hodgkin lymphoma, what is non-Hodgkin lymphoma. Their clinical features are a bit different. Hodgkin lymphoma more often localized to a single axial group of nodes. These may be cervical, mediastinal or periaortic. But in non-Hodgkin lymphoma, more frequent involvement of multiple peripheral nodes. Another feature is in Hodgkin lymphoma there is orderly spread by contiguity. Contiguity means spread to the nearby lymph nodes region. In non-Hodgkin lymphoma, the spread is non-contiguous. This can go anywhere. Third feature, mesenteric nodes and Waldier ring rarely involved in Hodgkin lymphoma. Waldier ring and mesenteric nodes are commonly involved in non-Hodgkin lymphoma. Extranodal presentation, this is rare in Hodgkin lymphoma, and extranodal presentation is common in non-Hodgkin lymphoma. This means Hodgkin lymphoma mostly this belongs to the lymph nodes. Non-Hodgkin may be in other tissues also. These are small differences in the clinical presentations. Now, what is the pathogenesis? Hodgkin lymphoma is a nucleus that arises from germinal center B cells. And a big organism, germinal center or post-germinal center B cells. EBV, Epstein-Barr virus, this infection is present in Reed-Sternberg cells in about 70% of mixed cellularity type. In other types, maybe this is positive in less number of cases or maybe negative in some subtypes. This EBV virus, this is present in the Reed-Sternberg cell in as many as 70% of cases of the mixed cellularity subtype and a smaller fraction of other classical formula of Hodgkin lymphoma. The structure of EBV genome, this is identical in all RS cells in a given case. This indicates that infection precedes, this occurs earlier, before, and therefore may be related to transformation and clonal expansion. So by these observations they conclude that most probably this infection is responsible for this transformation and then neoplastic change. Thus EBV infection probably is one of several steps contributing to tumor development, particularly of the mixed cellular type. Now this tumor cell, RS cell, this secretes certain cytokines like interleukin 5, this has special attraction for eosinophils, transforming growth factor beta, this is a fibrogenic factor, and interleukin 13. Now due to these cytokines, they will attract normal cells, normal eosinophils, some normal lymphocyte, macrophages, other things. Now this accumulation of these normal cells, this is not any, these are not simple innocent bystanders. They will themselves release some factors that will support the survival and growth of these neoplastic cells. So they are interdependent. Hodgkin lymphoma is a cardinal example of a tumor that escapes from the host immune response by expressing proteins that inhibit T cell function. There is expression of certain proteins. So red RS cells, they have high levels of PD ligands. These are special proteins, PDL1, PDL2, the special ligands. These will inhibit the T cell function. So this will dysregulate the immune response. The clinical importance of these proteins, PD ligands, this is clear from this observation that these patients, when these are treated with these antibodies against PDL1, so they respond to this treatment. That means these antibodies, these are effective even on those patients who are resistant to other types of therapy like chemotherapy, radiotherapy, other things. So this is very specific targeted treatment nowadays. Now there are different types of Hodgkin lymphoma. Mainly this is classified into classical Hodgkin lymphoma and non-classical Hodgkin lymphoma. Classical Hodgkin lymphoma, 95% of the cases belong to these categories, and these are four major types: nodular sarcoidosis, lymphocyte rich, mixed cellularity, lymphocyte depleted. In nodular sarcoidosis, what are the features? Collagen bands, and when we see the histology of these lymph nodes, I will show you these pictures. Collagen bands extend from the node capsule to encircle nodules of abnormal tissue. A characteristic lacunar cell variant of the Reed-Sternberg cell is often found. So this lacunar cell also is a variant of Reed-Sternberg cell. The cellular infiltrate may be of the lymphocyte predominant, mixed cellularity, or lymphocyte depleted type. Eosinophilia is frequent. These are features of nodular sclerosis. Then lymphocyte rich, scanty Reed-Sternberg cells. When we do any histopathology, we do H&E staining for the lymph nodes, like we do for the histopathological procedures. So these nodes will show scanty Reed-Sternberg cells, multiple small lymphocytes with few eosinophils and plasma cells. This may be diffuse or nodular. Mixed cellularity. The Reed-Sternberg cells are numerous and lymphocyte numbers are intermediate. Then lymphocyte depleted. There is either a reticular pattern with dominance of RS cells and sparse numbers of lymphocytes, or a diffuse fibrosis pattern where the lymph node is replaced by disordered connective tissue containing few lymphocytes. Reed-Sternberg cells may also be infrequent in this later subtype. So 90% of these patients of Hodgkin lymphoma belong to this classical Hodgkin lymphoma, and these are subtypes. 5% may be from the other group, that is nodular lymphocyte predominant type. Reed-Sternberg cells are absent, lymphocyte predominant, tumor B cells are present. So this is WHO classification of Hodgkin lymphoma and its features. This table is from Essential Hematology. Now this table from your book, Robbins, you can see the subtypes, same subtypes, morphology and immunophenotype, then typical clinical features. You can read this. I will narrate this also. Nodular sclerosis, frequent lacunar and occasional diagnostic Reed-Sternberg cells. These are present. Background infiltrate composed of T lymphocytes, eosinophils, macrophages and plasma cells. Fibrous bands dividing cellular areas into nodules. The RS cell, the neoplastic cell, Reed-Sternberg cells, they are CD15 positive, CD30 positive, and usually EBV virus, Epstein-Barr virus negative. In this type, typical clinical features, these are most common subtype. This is the most common subtype. Usually stage 1 or 2 disease, so we have very good prognosis in these patients. Frequent mediastinal involvement, equal occurrence in male and females. Most patients, they belong to young adult group. They are young adults. Second is mixed cellularity, frequent mononuclear and diagnostic Reed-Sternberg cells. Usually this RSL is binuclear. Here these may be mononuclear. Background infiltrate is rich in T lymphocytes, eosinophils, macrophages, plasma cells. Now Reed-Sternberg cells are again CD15 positive, CD30 positive, and most of these may be positive for the EBV virus. So 70% of these cases they have this infection, EBV virus. Clinical features, more than 50% they will present as stage 3 or 4 disease. This is advanced disease. I will explain what does this mean, the staging of this disease. Males are involved more than females. Biphasic incidence peaking in young adults and again in adults older than 55. So two peaks in young adults and then patient more than 55 years of old. Lymphocyte rich, frequent mononuclear and diagnostic reed-Sternberg cells, these are present. Background infiltrate is rich in T lymphocytes. The RS cells are again positive for CD15, CD30, maybe 40% of these may be negative for Epstein-Barr virus. Typical clinical features, this is an uncommon type. Males are involved more than the females, tends to be seen in older adults, and patients are of old age. Then fourth type is lymphocyte depletion. We have reticular variant where we have frequent diagnostic reed-Sternberg cells and variants of RS cells and a paucity of background reactive. Then the reactive cells are less in number. RS cells, these are again positive for CD15 and CD30. Most will be positive for Epstein-Barr virus. This is relatively uncommon type, more common in older males or HIV infected individuals. In developing countries, often presents with advanced disease. So in developing countries, poor countries like us, this may be more common form, and this is usually an advanced disease. Then lymphocyte predominance, frequent L and H or popcorn cell. Again, these are some variants of reed-Sternberg cells. These are present in a background of follicular dendritic cells and reactive B cells. Here, the RS cells are positive for CD20 and these may be negative for CD15 and CD30. Again, Epstein-Barr virus is not seen. So this is a bit different from the other types. So this is known as non-classical type. And all other 95% of the cases, RS cells are CD15 positive, CD30 positive. But here these are CD15, 30 negative and CD20 positive. Now you can see these pictures. Top left, A, Hodgkin lymphoma, high-power view of a lymph node biopsy showing two typical multinucleate reed-Sternberg cells. One with a characteristic owl eye appearance. This very big cell in the center. You can see this, if you can see this arrow. This very big cytoplasm. This is mirror image of each other. Two nuclei. Some hollow some clear space, hollow space. Surrounded by lymphocytes, histiocytes, and an eosinophil. So this type of cells, typical Reed's terminal cell, if we cut this in the center, so we can say this is mirror image of each other. So this is known as owl eye appearance, like the eye of owl. This next upper right picture B, mixed cellularity, different cells are there, and C is nodular sclerosing, lower picture, nodular sclerosing Hodgkin lymphoma. You can see these bands of collagen distributing the node into different nodules. So this is nodular sclerosing type. This will be histology of these different types of Hodgkin lymphoma. Now this is clinical staging of Hodgkin and non-Hodgkin lymphoma and Arbor classification. Now with the development of more and more effective chemotherapeutic agents and antibodies against, so maybe this is not so important, but before this was treated on the basis of this classification. The treatment was different for different stages. Now this is the procedure how we stage them. Stage 1, distribution of the disease. There is involvement of a single lymph node region. This is 1. Or a single extra lymphatic organ or site. And this means this can involve one lymph node plus something outside this lymph node or in the same area, same region. Then this will be, if this is going away out of the lymph node, then it is 1E, but this is present in the same area. 1R, 1E. Extension towards other organ other than lymph node, this is E. In stage 2, this is involvement of 2 or more lymph node regions on the same side of the diaphragm. If this is alone, this is stage 2. Or localized involvement of an extra lymphatic organ or site. There is localized involvement of some extra lymphatic site also. This is stage 2E. Stage 3, involvement of lymph node regions of both sides on both sides of the diaphragm. Without, this is 3, or with 3E, localized involvement of extra lymphatic organ or site. Lymph nodes are involved on both sides of the diaphragm. If this is only in the lymph node, this is 3. If this is involving some localized area other than lymph nodes also, then this is 3E. Stage 4, diffused involvement of one or more extra lymphatic organs or sites with or without lymphatic involvement. All these 4 stages are further divided on the basis of the absence or presence of some symptoms. If these symptoms are absent, this is A, 1A, 1, 2A, 3A, like this. If these symptoms are present, then we will stage them as 1B, 2B, 3B, 4B, like this. What are these symptoms? Unexplained fever, more than 38 degrees centigrade temperature, unexplained fever, drenching night sweats, too much night sweats, and or unexplained weight loss of greater than 10% of the normal body weight. These are known as B symptoms. If these are present, then we will label the case as stage 1, B, 2, B, 3, like this. If these are absent, then this stage is 1, 1A, 2A, 3A, 4A. This is clinical staging of Hodgkin and non-Hodgkin lymphomas. This is known as Ann Arbor classification. Before, the treatment was too much dependent on this staging. Now this picture, this is just to explain what is this stage 1, stage 2. You can see this picture carefully and you can understand in a better way. This is just to make it easier for you. What does this mean? Staging of Hodgkin lymphoma. Stage 1 indicates node involvement in one lymph node area. Stage 2 indicates disease involving 2 or more nodal areas confined to one side of the diaphragm. You can see the stage 1, stage 2. From left to right, you can see these two pictures. Splenic disease. Stage 3 indicates disease involving lymph node above and below the diaphragm. Splenic disease is included in stage 3, but this has special significance. Then stage 4 indicates involvement outside the lymph nodes, outside the lymph node areas, and this refers to diffuse or disseminated disease in the bone marrow, liver, and other extranodal sites. So this is how we were doing this staging. The stage number in all cases is followed by the letter A or B, indicating the absence or presence of one or more of the following: unexplained fever of 38 degrees centigrade, night sweats, or loss of more than 10% body weight within 6 months. We have discussed all these things. Localized extranodal spread to the lung or spinal theca would be classified as 1E. As involvement of the spleen is often a prelude to widespread hematogenous spread of the disease, patients with lymph node and splenic involvement are staged as 3S. Bulky disease, widening of the mediastinum by more than 1/3, or the presence of a nodal mass more than 10 cm in diameter, is relevant to therapy at any stage. Tumor burdens, how much this tumor, this will be also important to decide for therapy. Now these are some pictures, histological pictures, what we will see in the lymph nodes. Hodgkin lymphoma, lymphocyte predominant type, numerous mature looking lymphocytes surrounded, scattered, large, pale staining lymphohistiocytic variants. These are known as popcorn cells. This is another picture, Hodgkin lymphoma, mixed cellularity type, a diagnostic binucleate reed-sternal cell is surrounded by reactive cells including eosinophils. These are bright with bright red cytoplasm, lymphocytes and histiocytes. So this is mixed cellularity type. Hodgkin lymphoma, nodular sclerosis type. A low power view shows well-defined bands of pink acellular collagen that subdivides the tumor into different nodules. You can see two big nodules here, and this pinkish, this is collagen of band. This is dividing these into different nodules. This type of histology we will see in nodular